So today we're going to talk about gut health and mycotoxins and how mycotoxins affect gut health. We're also going to discuss how there's some myths out there and help you understand where they come from, etc. So I get so many emails every day from all over this country and other countries, not understanding that, just following the straight, narrow, oh, I thought this does that, because this is what they read when they Google things. But what the real science says about that is different. And as you know, I'm evidence-based. I take everything very seriously, including the fact that you should not believe everything you read on Google. You should actually go and look it up in either medical journals or medical textbooks. They're there. And some of you do actually do that, and I congratulate you for that, because that's really quite helpful. Let's get started. So this is the disclaimer that I have to put on, and what I mean by this is that I want to educate. I don't want to make money. I'm here to help people because so many others are making money off of false diagnostic tests and false treatments. So let's talk about the gut. There's 4 things we're going to talk about. The first is barrier function. The gut serves as a barrier. Okay, it keeps things from inside the gut from going outside the gut. Then how does it do that? It has several layers. These are anatomical and histological, meaning cells. And there's 3 cell types, and there's 3 layers of protection. And that's how our gut works. So let's go over the 1, 2, 3, 4. The epithelial barrier, that's that lining inside the gut. It's a single cell epithelial barrier. It's the first defense against mycotoxins. And it depends on the combination of 3 things, basically. The microbiome, the microbiota, this one layer of epithelial cells, and the immune cells in the lamina propria of the gut. We'll explain this. The epithelial cells, that first line of defense, is actually connected to each other. They're one next to the other, and they're connected by what are known as desmosomes, adherens junctions, and tight junctions. So those are that's that first barrier against things. Then there's 4 layers. There's the mucosa. Okay. We're talking from inside out of the gut. First is your mucus, okay, the mucosa. Next comes the submucosa, then the muscularis propria layer, and finally the muscularis mucosa. I know that this is probably basic anatomy and histology and things like that, but I just thought we'd cover it all anyway. So this epithelium of the intestines, there's 3 cell types. 80% is epithelial cells. Then there's the mucin producing goblet cells in the villi. The villi are these like finger-like projections. Okay. And the Paneth cells, which produce antimicrobial peptides, AMPs, in the crypts. So just be aware that if you took the intestine, the gut, and laid it out flat, it would cover a tennis court. It's the size of a tennis court. So it's huge. And again, the epithelial cells connected by the desmosomes, adherens junctions, and tight junctions. And these form a mechanical bond of cells next to each other, and these produce a physical barrier. This barrier blocks the entry of large particles and pathogens. What are pathogens? Bacteria, etc. And it's permeable, however, to water, electrolytes, and dietary nutrients. So it keeps bad stuff in, and it allows good stuff out. Next is the chemical barrier, and that's made up of mucus, these antimicrobial peptides, and then cytokines secreted by the epithelial cells. And that's part of the immune part. The third barrier is the immunological one, and it consists of the lamina propria, which contains capillary and gut-associated lymphoid tissue. Many of you remember this from med school. It was called GALT, and it's made by immune cells. Macrophages, remember macro and phage. In Greek, macro, large, phage, eater. They eat and ingest these bacteria, dendritic cells and lymphoid cells. In addition, they secrete IgA, immunoglobulin A, and cytokines that we mentioned in the previous slide. And these complete this projective layer. So the gut barrier is three systems, that, that help, that are interrelated, integrated with each other, and interlaced with each other. The first is the microbiome. The second is the physical and chemical barrier made up of the epithelial cells and secretions. The third is this immune barrier that I just mentioned in the previous slide. All three work together synergistically. And so when these work, it's wonderful. So there's information, there's more nerve cells in the gut than in the spinal cord. And this is called the enteric nervous system, and we'll get into that a little bit later. But you will have some more information. Then the microbiome is actually persistently, and continually exposed throughout life to foods, liquids, and chemicals. Having said that, look at these two numbers. The total number of cells that make up our body, human body, is about 37 trillion. That's 37 with 12 zeros. The total number that make up the microbiome in the gut is 135. So 100 trillion more, 4 times. The human genome, 23,000 genes. The microbiome is made of 8 million genes. And 1 milliliter, which is basically a small drop, not a big drop, a small drop of colonic fluid, contains more bacterial elements than there are humans on the planet. So, now the gut microbiome, this is all the microorganisms that are inside the gut. Okay, and that's bacteria, there's viruses, there's fungi, and there's protozoa. And these have been living there since, you were about 3 or 5 between those years. And the main phyla are Firmicutes, Bacteroides, Actinobacteria, and Proteobacteria. Anytime you get an imbalance in these, you become ill. The function of the microbiome includes making vitamins, enzymes, and amino acids, the absorption of minerals and nutrients, okay, and the breakdown of large molecules, and lastly, and very importantly, in producing short chain fatty acids. Now, all this helps us live. Now, here's the important part. Beginning was explaining to you what we're looking at and the different layers and what the cells produce, etc. So the microbiome can transform the toxicity of mycotoxins by several different ways, most of which change and modify how toxic these mycotoxins are and diminish their toxicity. So there's two basic mechanisms involved. One is the change of the structure of mycotoxins. By biotransformation, they literally transform mycotoxins. And the other is by changing the absorption of mycotoxins. The most common way it's done is the chemical transformation by enzymes that are present throughout the gut from microbial cells and those excreted by these microbes or microbial cells into the gut. These reactions are called hydrolysis, and they hydrolyze these mycotoxins and therefore reduce their toxicity. Another effect by the gut microbiota on mycotoxins, the ability of components of the microbes, mainly cell walls, LPS, lipopolysaccharides, to form adducts, or in other words, to form a chain and bind to mycotoxins, reducing so they can't be absorbed. So bacterial and protozoal fractions, for example, are able to degrade trichothecene mycotoxins, which are pretty strongly toxic, such as satrotoxin, T2 toxin, and others. And in a study, they showed, and then it was followed up by several more, that these two bacteria, Prevotella and Butyrivibrio, these very effectively essentially neutralize T2 toxins, and that fecal microbiota hydrolyze deoxynivalenol, also known as vomitoxin. So what do you get from that is that this myth that mycotoxins colonize the gut, so you have to pull them out with binders, is a myth. It's not so in evidence in medical science. So it's not, that's just a myth that's, you know who spread these myths. Anyway, two important points. One is a mold that produces mycotoxins doesn't produce one mycotoxin. It produces a whole series of mycotoxins. And two is that if a mold known to produce a mycotoxin or mycotoxin is present in a home or building, those mycotoxins are present as well. Very important point to remember. And let's talk about size. Hair is 100 microns. Spores are 2 to 4 microns. Mycotoxins, 0.1 microns, the size of a virus, okay? And exposure to mycotoxin by inhalation, dermal absorption. Ingestion is minimal, and we're going to show you why it's minimal. But basically, these are the size of viruses. Now, if you're going to test for a virus, do you test by a blood test? Do you test Epstein-Barr virus, cytomegalovirus, herpes virus, hepatitis A virus, B virus, C virus? Do you test it through urine, or do you do a blood test? Well, obviously, everybody knows you do a blood test, not a urine test. So don't get pulled in by all the marketing where they spend and they teach you and they do all kinds of things to convince you to use their labs. Okay, So as I mentioned before, that we're going to talk about the enteric nervous system, the nerves that feed the gut. The enteric nervous system is a specific part of the autonomic nervous system. And it's in the wall of the gastrointestinal tract, all the way starting in the esophagus to the rectum, and it's responsible for the activity in the gastrointestinal tract. As far as numbers, like I mentioned before, after the brain, this has the largest number of nerve cells. So it's that gut, all the nerves that feed the gut, there's more of them than there are nerves in the spinal cord. In addition to neurons, the enteric nervous system includes a number of glial cells that's where, glial cells are also found in the brain. But these are found outside the brain. These are called enteric glial cells, EGCs. And EGCs play an important role in the pathogenesis of neurodegenerative diseases, including Parkinson's, Alzheimer's, and Creutzfeldt-Jakob disease. Now, I had a patient recently with Creutzfeldt-Jakob disease, a dentist, and he checked his practice that was not there. And then he checked his home, it was in his bedroom. So the mold was growing in his bedroom, not in his office or anywhere else. And he had Creutzfeldt-Jakob disease. Now, what does this tell you? That these mycotoxins affect this ENS, enteric nervous system, by demyelination. What happens when you demyelinate these nerves? The gut doesn't work as well. So therefore, things like SIBO, Irritable Bowel Syndrome, Crohn's disease, ulcerative colitis, all can occur because the gut, which has its own nervous system, can't move like it should. So I treated a young girl, 20 years old, who had to be fed intravenously because she couldn't eat, because it would all sit there in her stomach. Well, loss of myelin. Her stomach couldn't do it what it's supposed to do. So imagine if certain parts of the gut don't move and certain others move, but too much. That's what's happening. The mycotoxins also affect the nerves by what is called mitochondrial dysfunction, and that causes cell death, also known as apoptosis. Now, I know there's all kinds of summits. I wonder what these summits are. Are these people actually sitting on top of a mountain, or they think they're on top of a mountain? But anyway, mitochondria, how to treat mitochondria and all that. Well, treat the cause, not what happens because of the mycotoxins. You're not going to get mycotoxins to go away just because you think you're treating mitochondrial dysfunction. Also, in this enteric nervous system, mycotoxins produce reactive oxygen species and oxidative stress, and we know that these are not good. So what's the result? It alters the motility of the gut, the secretions, the conduction of sensory stimuli. These people all of a sudden have, their gut feels awful, like it's always distended. They complain of pain, etc. And it alters the regulation of blood flow in the intestinal wall. So let's go now to this study by a friend of mine, actually, Dr. Jack Thrasher, worked in my medical center for several years. And then he moved to New Mexico. So in this paper, he writes that damp or wet building materials occur from a variety of construction defects, roof leaks, the condensation in your air conditioning. You can see that now that it's getting warmer, when a car pulls out of a parking spot, there's like a pool of water there. That's that dripping from the AC system in the car. There's water intrusion from floods, hurricanes, leaking appliances. Have you ever checked behind your dishwasher? Just as an example, leaking plumbing, poorly designed foundations. For example, basement walls that allow water seepage from wet soil, or because of the slope of the building lot leads to water accumulation under the concrete slab. I hear that all the time about how people tell me how their basement is moldy, and they think by shutting the door that's going to make mycotoxins not come up. Well, mycotoxins are the size of a virus. So remember the pandemic, it didn't matter what, it went everywhere. Now, here's something I wanted to show you, because when they test things, this was in a study, you can see aflatoxin is 0. They don't find it. And that's why MyMycoLab doesn't test for it, because it's very rare. You can see ochratoxin A, and you can see trichothecenes is where everything is happening. Now, unfortunately, in this study, they didn't include ochratoxin B, because they would have found more, and that's why MyMycoLab does ochratoxin A and B. But what I'm trying to show you here is aflatoxins don't affect you. And this study showed how many of these were in parts per billion. And this is this is in the HVAC ducts, dust from the refrigerator compressor, and one home with a dirty filter in the intake of the air conditioning duct. Here's another one, ERMI. Everybody's running to do ERMI test or EMA. Please don't do them. They're no good. Look at the date of this official announcement from the EPA, August 2013, 10 years ago, and people are still rushing out there to do that, ERMI, because that's what they're told to do, or that's what they read to do. Well, don't do it. It's not a good way. It's not an effective way to do anything. And in this study, the medical relevance of fusarium by Dr. Hoff, one has to admit today the risk of acute intoxications of humans is low, at least in developed countries where the amount of mycotoxins in food items is controlled by the authorities. What does that mean? It's not from food. Excuse me, it's from the indoor air. Here's another one. It's important to mention that mycotoxins are systemically bioavailable irrespective of the route of exposure. They're everywhere, so they get in you everywhere, especially people don't think of the skin, but it's there too. Sorry. And here's another one. This is in a study a year ago. I'm sorry, it was accepted in last summer. In order to provide a secure identification and characterization of indoor mold, this is where these companies come in and they do air traps, etc. Listen to what you have to do. Swab directly contaminated building materials, swab samples and sampling of air on different media, like object slides, petri dishes with filter material and agar, with subsequent microscopic or morphological differentiation, are more reliable alternatives applied in routine analysis. And unfortunately, these companies come in, they charge a small fortune, they tell you this is what you have, but it doesn't tell you where. Anyway, here's another study for you. This is from a study done 10 years ago. because of the serious concerns for animal and human health, regulatory guideline levels for deoxynivalenol, which is also known as vomitoxin, in food and in feed are enforced in more than 40 countries. Where is the problem really that they have these things in food? It's in certain countries in Africa where storage of grain is poor, Ivory Coast, and in a few other countries, and in Eastern rural China. It's not in our food. So here's vomitoxin, also DON, deoxynivalenol, from this study by Dr. Hoff. And it's able to produce several mycotoxins in huge amounts. It's widespread in contaminated indoor environments, not food. And when it's in that indoor environment, it can adhere to foreign materials such as indwelling catheters, artificial heart valves, joint replacement, and grow on those. Okay. Lastly, the risk of acute intoxication is low in developed countries where it's controlled. The amount of mycotoxins are controlled by the authorities. So it's not in food, it's not in the gut, and you don't have to take binders to pull it out. I love that term. I'm pulling it out with bentonite. I'm pulling it out with cholestyramine. There's nothing to pull. And you saw where the gut neutralizes these anyway. So let's take a worst case scenario. And I want you to look at the last 3 lines. An adult weighing 170 pounds would have to consume at one sitting 14 pounds of oatmeal. Now remember, this is oatmeal that's rancid, that's contaminated with mold and mycotoxins. So it smells bad, tastes bad, looks bad. Or they would have to eat 20 slices of rancid bread. Then they would get sick. Well, I'm so sorry. You don't have to take binders to pull these things out because it's not there. So we know that certain foods contain mycotoxins. And as I said before, this commonly occurs in foods with poor storage after harvest, mainly in some areas of Africa and rural China. NIH knows about this, CDC knows about this, and we know that it's the amount found is parts per billion. It's too little to cause any serious health effect in humans. Let me explain a part per billion. I know I've explained this to you before, but I want to explain it once again. Parts per billion is essentially, I asked a scientist because I don't know what this is either. And that is, I said, I need a visual picture of what parts per billion is. And he says, okay, what it is take 100 football fields, cover them with golf balls, take one golf ball out, and that's part per billion. So when you have a food that has 4, 5, 8 parts per billion, you're talking about a very, very small amount of mycotoxins. So when they measure it, they're all below what is called the tolerable daily intake, TDI. And this is set in our country, FDA, in Europe, the European Food and Safety Authority, UN Food and Agriculture Organization, the World Health Organization, all kinds of people say this is the tolerable amount. You can't have more than this. And again, it's like less than 10 parts per billion. So like cereal, beans, fruits, grape juice, beer, coffee, okay? But it's excreted. And for that reason, mycotoxins can be found in urine in parts per billion in healthy people. Now, 2 summers ago, Frey showed that 4 mycotoxins were found in cow's milk. 91% of all the milk tested had at least one mycotoxin, and 30% had 2 to 4. However, all of these were below the tolerable daily intake, TDI, and easily excreted in urine, as are most mycotoxins found in beverages and food. This is why testing for mycotoxins in urine is not helpful in trying to assess mycotoxins from any indoor space. I hope you understand that. So here's another study by a group of doctors. So where are these mycotoxins found? Again, I say predominantly in countries lacking implementation of adequate food safety policies. And remember that notably one mold species can produce several mycotoxins, vice versa. And different molds can produce the same mycotoxin. First point of contact is breathing, inhalation of mold spores and mycotoxins. There's even a connection between mycotoxins and Parkinson's disease. So let me give you a little more information about that. There's 2 studies, actually 3 studies that have come out. One is that they took the brain of patients who had died and who had had Parkinson's disease and found mold and mycotoxins in all parts of the brain, including the cerebrospinal fluid, the CSF, all parts of the brain. In another study at a different institution, they did the same with Alzheimer. Same results. Every brain, not a high percent or some, no, every brain had molds and mycotoxins in them, including the CFS, cerebrospinal fluid. And also, this was found in the latest study, which was in ALS, amyotrophic lateral sclerosis, Lou Gehrig's disease. Now, you've all heard of patients with POTS, chronic fatigue syndrome, myalgic encephalomyelitis, and mycotoxins. How are they linked? This is a study by Dr. Tamara Tuominen, and she did a great job at explaining this. So let's look at binders, which is, in my opinion, really important because so many people spend 2-3 years sick. So anyway, what you need to learn is this. This is what study showed. Binders rely on the absorption of mycotoxins for the gut. That's what they're supposed to do, and prevent it from going into the bloodstream. And these binders are kaolinite, clays, activated charcoal, zeolite, bentonite, all of that. They're effective in neutralizing aflatoxin only. They are ineffective in neutralizing all the other mycotoxins. In addition, they also bind vital vitamins as well as macro and micro elements. Now, if you remember back here, I showed you this, where it showed what kind of mycotoxins do they find in how many are in my aflatoxin, the first column? None. So that's what binders do. They bind that mycotoxin that is not found. So, and here's the other thing, they bind vital vitamins as well as macro and micro elements. Well, I think you have to understand that they say to you, oh, you have to take it apart from this and apart from that and apart from. How do you know? Show me one study that says you take it 2 hours or 4 hours or 3 hours or 1.5 hours or 5.5 hours. There's not a single study. It's all basically by anecdotes, stories. My name is, John Smith, and I took this and I felt great. That doesn't make it medical science. So, urine testing. Here's a study that came out just a few months ago that says that the variability of mycotoxins concentration in urine and its volume based on daily intake, because some days you drink more, you drink less, you sweat more, you sweat less, whatever. Demands, so they say it demands urine sampling at different time points during the day. And the normalization of results with creatinine concentration. Okay. So it's not send in one sample, it's sending, they actually advised 6 samples from throughout the day. The inter-individual comparison of mycotoxins, I mean that one person and it's 6 different urine for that day, because of various factors such as gender, age, diet, and muscle mass, can influence creatinine secretion. They went on to say, and this is this study, as you can see at the top, and it's done by Cargott and these others, the analytical validation of a direct competitive ELISA for multiple mycotoxin detection in human serum. So ELISA method, the antibody testing to detect mycotoxins in human serum, comes with significant, with significant accuracy, precision, and specificity. Actually, the MyMycoLab antibody test for mycotoxins is 97% specific. Now, the other part is I show you this because the CDC says use of invalidated urine mycotoxins tests for the low levels are found in many foods. Mycotoxins are found in the urine of healthy people, and it shouldn't be used as a diagnostic tool. Now, here is the results on the left before, on the right after, of a lady that did this test. And she writes, "Thank you for the gift of mycotoxin antibody test, and thank you for the gift of health." And guess where it was? It wasn't in their home. They had their home tested, cleaned, all kinds of stuff, nothing. It was in their truck, in their pickup truck. Okay, that's why you see here at the very last, no more running in the moldy truck. But you can see how the treatment helped. And that's a measure. You can actually see the change. Now, here's what I get all the time. You know, I have consulted different medical doctors and naturopath, but nothing has worked. My current naturopath has me on binders, zeolite, clay, charcoal for about 6 months, and I'm convinced they're not binding the toxins. I've studied your videos. I believe I need itraconazole. The naturopath gave me a course of nystatin. That's the wrong medication. Let me show you why. Okay, so there's 2 types of molds. There's single cell molds and multiple cell molds. Single cell are yeasts, like Candida. And the effective treatment is actually fluconazole, not, you don't want to use a weak mycotoxin like nystatin. It's very old and very weak. You should use, if it's only yeast you're dealing with, diflucan. But diflucan or fluconazole does not affect multiple cell molds. What are multiple cell molds? Aspergillus, Stachybotrys, Penicillium, Cladosporium, Fusarium, okay? They're ineffective. So itraconazole or Sporanox is effective against all the molds plus the yeasts. So why not take a chance? Why take a chance and just take fluconazole thinking, oh, this is yeast? Get them all. Anyway, so I want to tell you about a success story. This was a patient of a doctor who really took an interest in this. This is a patient of Dr. Gail Rogers. She's a chiropractor. And she's very thorough in everything she does, but also, she doesn't have to hesitate in calling me or emailing me immediately if she has a question. And I invite all of you to do the same. I'll be happy to train as many people as you want, if you would like, and give you the same results as Dr. Rogers had. So this is Hope. She's a wife and a mother of 3 little girls. She's 30 years old. She suffered from Lyme, mold and mycotoxins, gut dysbiosis, histamine intolerance, and was very, very tired. Now, why am I sharing this? She wrote this under each picture. Picture is scary. I look like an addict or something. This is a few weeks after being treated for Lyme and before I knew I had a mold issue. Now, a little bit later, a year later, I would never dream a year ago that I'd be well enough to be taking my girls by myself for a day at the beach and having the energy to do it all. But here's more. This is SIBO, obviously. This is before she started itraconazole, June 10th. So 3 months later, September 12th, this is what, after taking itraconazole, okay? So she took these pictures, as you can tell yourself. And here's her takeaways. We couldn't find any mold, but later, after returning home, they went on vacation and they opened the front door, came back, opened the front door, almost knocked over by the smell. And so we finally came to grips with the fact that our house had a mold problem, even though we were never able to find it. We moved out. We tried decontaminating as many possessions as possible. In retrospect, it made us all much more ill. If I had to do it again, I would get rid of almost everything except for a few irreplaceable items. And at the bottom, you can see if I had to do it over, I would just shut the door and walk away. So here's your timeline. Summer of 2020, treated for Lyme. September, positive for MyMycoLab. Winter 2021, moved out of their home. Spring, health began improving. July 2021, started itraconazole. Almost a year after her positive MyMycoLab mycotoxin serum antibody test. She tried natural remedies before this, and she tried to heal her gut, but it didn't work. So here she is. She's been hitting some really great milestones, less chemically sensitive, more stamina, not as much pain, breathing is easier. She's more satisfied when she eats, and on the right clip, it tells you not to mention that I've always wanted to go on a backpacking trip with my husband. I was able to go for the first time ever. She's a happy person. And this could be your patient too. So here's what the emails say for me. I was wondering if you could recommend a doctor. It's for one of the women in my group who has been on these crazy Shoemaker Nathan Gupta protocols for quite some time to no avail. Okay, and here's another one. Is it me, or do the majority of mold practitioners look at this as a cash cow, or at least the Shoemaker practitioners? They make a lot of money telling patients the same thing over and over. Take the VCS test, take fish oil and cholestyramine, clear the markons, fix the hormones, do VIP to fix the brain. That's it. Seems fairly simple. Only problem, I've been doing it for 3 years and it doesn't work. By the way, markons does not exist in medicine. That is a total Shoemaker thing. Here's another one. After 2.5 years of trying to heal my gut, I'm not satisfied with my naturopath's treatment of not addressing mycotoxins and SIBO. So, and the previous experienced doctor for 2 years, so here's 4.5 years she's sick, was only treated cholestyramine and the modified Shoemaker protocol. It's not going to work. This is from a doctor, professor of medical school. He did testing with MyMycoLab on himself. He was having issues with his eyes, and I should send him an article on how this affects the eyes and the vision. He did the treatment I recommended, and now his eyes are back to normal. And this is the study I sent him, and he sent me this as a follow-up. I told you that after moving out of the moldy home and taking itraconazole and your recommended nutraceuticals, that my eyes were better. I saw my ophthalmologist Friday. Virtually all is back to normal by exam. And here's a couple more, and then we're done. Completed the testing in 2022 with MyMycoLab, and then was extremely unwell, and etc. Results showed high levels of many mycotoxins, both IgE and IgG. That's the wrong term there. Initially, I sought treatment with a doctor that follows a Shoemaker protocol. The protocol focused intensively on binders and use of mast cell stabilizer. I would describe the success of the treatment as poor. I'm working with a new doctor who is very open to exploring treatment protocols backed by peer-reviewed science. Having now eliminated my exposure, I'm taking itraconazole to help deal with the terrible bloating I'm experiencing, just like Hope did. You saw her stomach before and after. And this is the last one. It's addressed to me by this poor patient. I'm aware of the courses given by urine labs. Much of the information in these courses are not supported by medical science, and this makes it very difficult to get traditional medicine to get behind molds and mycotoxins, as well as to have valid codes so that insurance companies pay for testing and treatment. Shoemaker is now promoting a test that has no validity in medicine, the VCS test. Others, such as labs that perform urine tests, do not give results that have anything to do with indoor environmental exposure to molds. And she sent me a study. Many of these so-called experts have never published anything in peer-reviewed journals nor lectured at medical universities. Their expertise lies in marketing themselves on the internet and making more money. Very true. Let me address something on itraconazole, how safe. That is a big question I get all the time. It's been in use for 30. Let me see if I can do. Okay, I'm going to do a share screen, but first, this is my last slide. So if you have any questions, if you want anything from me, do send me an email at immunedoctor@gmail.com. Okay, so I'm going to show you some slides that tell you how safe. Everybody's so scared, but you have to read the medical literature, not the internet. The internet is meant to frighten you. So, here is itraconazole and cancer. The first slide, itraconazole, also known as Sporanox, is a common antifungal agent that was developed in the 1980s. It has been in clinical use for 35 years with an established safety record. That's what you need to know. It has an established record as being safe. You can try to, if you think that the package insert with itraconazole is also frightening, do the same with penicillin or some over-the-counter medication. I don't know, Claritin, Pepcid. Read the package insert. And then I have a question regarding any chance we can add total IgG and total IgE to the mycotoxin antibody panel? First of all, IgG is not in and of itself enough. IgG is the only immunoglobulin that comes with 4 subclasses. And IgE is by itself, doesn't have any subclasses. But here's the thing: say you're allergic to pine dust from pine trees. Your IgE is going to be elevated, but that's not going to affect the mycotoxin antibodies, because this is a serum antibody test. So say, or you're allergic to cats and you went to visit somebody and they had a cat or two. Your total IgE is going to be elevated. It's going to react. It's supposed to do that. Okay. But it's not going to be, it's not going to affect the test. Same with the IgG. If some people are either, and what you'll find with IgG is that the level is normal, but if you go to the 4 subclasses, and as an immunologist, this is real common, you'll find 1 low and 3 high, so they average out, or 2 low and 2 high, so they average out. But that doesn't affect the antibody reaction. What is the duration of itraconazole treatment? In textbooks, it says, medical textbooks, it says anywhere from 12 months to 18 months. I don't do it like that. I found that by using nutraceuticals, supplements, I can do it in 6 months. And basically, I rely on one question to a patient: how do you feel? If they tell me I feel fine, they don't need anything anymore. The only test you need to, the way to test for it is you do a mycotoxin serum antibody test from MyMycoLab, and then you repeat it at 6 months, so you can compare, just like I showed you the before and after. And I see another one here about patients who don't tolerate itraconazole. Typically, that's because they're also taking several either pharmaceutical drugs or supplements that affect them, and those are the ones that can't take it. Otherwise, I'm willing to bet, although I don't gamble, but I'm willing to bet that a lot of these patients are on a bunch of supplements, and that's why they can't take the itraconazole. The other alternative is to take any of the other azoles except for fluconazole. What labs do I recommend who can check for molds in your environment? I mean, I get that. I mean, don't forget, I talk to doctors in New Zealand, in Cambodia, in France, in Switzerland, in India, in Israel, etc. I don't know. I can't keep track of who to recommend in those countries. Here in the West Coast, I recommend Design Well Studios, and on the East Coast, Enviro Health, but that's for the United States only. For those who want to know what nutraceuticals I typically recommend, if you would go, you should go to MyMycoLab.com, and on the top, click on video, and you can find my webinars. I just did one 6 weeks ago on treatment. So you should go there, and because it's an easy hour-long discussion. And then another one who read the warnings about itraconazole and should not be taken with statin. No one should be taking statins to begin with. Dr. David Perlmutter, a friend of mine who's a neurologist, who's quite well known for several books he's written, the first thing he does when somebody comes in with a statin is take the statin away from them, because it eats away the myelin. So patients come see him with issues such as demyelinating disorders, such as multiple sclerosis, etc. Statins. Statins are good for about 6 months after a heart attack, but everybody's put on them regularly. You shouldn't, I wouldn't recommend statin to anyone if they've not had a heart attack, and that's only in the first 6 months after the attack. Okay. So if you read the drug interaction for a lot of medications, you will find that they do have interactions. So again, for the supportive supplements, go to MyMycoLab.com, click on video, it's at the top of the screen, and watch my webinar on treatment. And if you watch some of the other webinars, you will see where I added a lot of discussion on itraconazole, so you can read it. Like for instance, people give glutathione. Well, if your patient has gliotoxin, if you're so good at reading everything, then you should have read this. Glutathione will increase the toxicity of gliotoxin. But people put, I mean, say you need to tell their patient you need to be taking this glutathione without checking in the literature, is this okay for a patient who has gliotoxins? So, how often does MyMycoLab get a negative? We rarely ever get a, because most people who send in their blood are sick. So people who are well don't go and say, I want a blood test for mycotoxins. Well, have you found that individuals who have SIBO recover after taking itraconazole? Yeah. So, I mean, I think you saw hope here. Here's her picture with SIBO. She wrote all this at the bottom, by the way, pre-itraconazole and 3 months later. So yes, it's real, it works well. And voriconazole is the other antifungal that I give. The other, the supplement antifungals don't work. I mean, again, you saw how many emails I get, and I get 5 to 10 a day, 7 days a week, 365 days a year. So I hear of all the different medication, not medication, supplements being given, and etc., and they don't work. Itraconazole does. Not only that, but I've published over 100 studies. So, and I can show you these studies that show how itraconazole really works for molds and mycotoxins. That's the main point. It's not my opinion that matters. It's what is medical science that matters. Opinion, you know, authority is not the truth. Truth is the authority. Okay, here's another one. I used itraconazole and had some symptoms at the beginning, but as I continued its use with all the supplements Dr. Campbell recommended, I felt better. Does the body get used to it? No. No, it doesn't. It's just a very effective treatment for molds and mycotoxins. And it, very importantly, it crosses the blood-brain barrier. And if you remember from the lecture I gave you on the issue on the enteric nervous system is demyelination. So if you want to heal the gut, you need some itraconazole. Any further questions? We're coming on the Cinderella hour. Oh yeah, the first place mycotoxins attack is the brain, not the gut. It's the brain. It crosses right through the blood-brain barrier and hits the brain. And that's why you get brain fog and short-term memory loss, sleep disturbance, anxiety, depression, and all these things. And are gliotoxins tested with your test? Yes, one of the tests we use. And what is the mechanism for the itraconazole treating the mycotoxins? Well, actually, mycotoxins are secondary metabolites of mold spores. You don't really have molds, you have mold spores that you breathe in. So your hair is 100 microns, as I showed in the slide earlier. Mold spores are 2 to 4 microns. Okay, and attached to these mold spores are mycotoxins. Kill the mold spores, there's no more mycotoxins. So, and thank you, Dr. Susan. Yes, the spores are actually in your body. They get in your body. They don't go out. Once you get the spores in, the most common, yes, and it's called colonization, and the two most common places are the lungs and the nasal sinus passages. Those are two most common places. The nasal sinus passages really has a very short trip to get into the brain. And that's why it affects the brain. And I have a webinar that you can look up again by going to MyMycoLab.com and clicking on video. I gave 2 lectures on the brain, part 1 and part 2. Spores from ground glass nodules in the lungs. No, it does sometimes look, when you have inflammation from spores in the lung, it looks like what radiologists will call ground glass. In other words, like the window in some bathrooms is kind of like that, opaque. That's what you'll see. What are the effects on the heart? Demyelination. So that's the most common effect of molds themselves. That's why a study done at Rutgers University School of Medicine 13 years ago, or 12 years ago, I forget which, 2010, so it's 13 years, showed that 66% of people with MS, multiple sclerosis, it's due to the effects of mycotoxins. So MS is demyelination. It's a demyelinating disorder, and it's caused by mycotoxins. Can mold mycotoxins cause AFib? AFib is a disease where the rhythm is off and it fibrillates because the nerve is demyelinated. So yes, we're talking demyelination here. And we're also talking in this particular webinar about gut motility. Imagine some parts of the gut move as normal, others way too slow, and others way too fast. What happens? The studies done for the nasal passages, the main one was done by Dr. Ponikow, chairman of ear, nose, and throat surgery at the Mayo Clinic, published a study on 210 patients that he took to the operating room, removed all the gunk, sent it to the lab. In the 210 patients, 96% had mold. So he actually petitioned that it be changed to chronic fungal sinusitis. And his treatment was oral itraconazole and amphotericin B nasal spray. Since he published that study, there's been a number of other studies that have come out with that. By the way, that study is 24 years old. Do the sinuses ever require local treatment, a spray, the nasal spray, and itraconazole? And that's been shown not only by Dr. Ponikow's study that I just mentioned, but in several other publications and about treating fungi and mold spores and mycotoxins. Any other questions? Maybe I should do it like in the auctions, going, and gone, and then they have this big hammer. Can you use oregano? Nope. If oregano worked, everybody in Italy wouldn't need an antifungal. That's a joke. It was told to me actually by Dr. Sinatra of Italian origin. There are PubMed studies. Yes, there are, and they're very limited. And they don't, they're usually very unconvincing in their effectiveness. So, any other questions? And by the way, if you feel, go ahead and do the oregano. And after 6 months, they're still sick, then do the treatment I recommend, because it takes 6 months for a patient to get well that I treat. I think the reason that 12 months is because the studies in medical textbook chapters give only itraconazole. They don't give any other supplements. And after doing this for 25 years, wait a minute, no, it's more than that, 27 years now, gosh, I'm getting old, and over 15,000 patients successfully treated, I found that using the supplements, certain targeted supplements that I discussed in my webinars for treatment, and by the way, they're in the medical literature as well. This is why you can cut it down to 6 months, and I've seen that, oh man, thousands and thousands of times, 6 months. Here's the problem that is treated with chronic Lyme disease. I wrote a study, and I'll be happy to send it to you if you email me, on is it Lyme or is it mycotoxins? These people who, just like this gal that you're looking at on the screen now, she was treated for Lyme for 1.5 years. Does she look? Here's her picture after treatment for Lyme. Okay. And this picture was taken a few weeks after being treated for Lyme. Does she look healthy to you? No, of course not. And so it's when you give all these other things. First of all, what does chronic Lyme disease do? All these antibiotics destroy what? They destroy the microbiome, number one. Second, again, you can't take itraconazole and some of these other things that we don't know if there's any cross-reactivity. Do you know of any studies that show peptides have cross-reaction? No, they're too new. What are my thoughts about mold detection or diagnostics in primary care? Do PCPs know to think or look for this? It took me a long time to find my way here. Yes. Part of the reason is that traditional medicine looks at all the BS out there, just like what we've talked about today, all the myths and everything that everybody follows, and they just throw up their hands and say, I'm not going to get involved with that. So that's what I can tell you. But I can also tell you that the doctor for this young lady has now done almost 500 patients in the last 2.5, 3 years that she would have not been able to cure before. Or I don't think she would have been able, because she's such a, first of all, she's intelligent. She watches the webinars, et cetera, and she sees the results. And that's what you want. You want the results, not the arguments. Or the anecdotes. So what you have to do with these patients, take them off everything else and start them on a paradigm for their treatment for mycotoxins, and not combine it with something for treatment for something else. All righty, folks. Any other questions? Great. Hope I was able to teach something to y'all. First of all, diflucan doesn't work against, it only works against yeasts and not molds, multicellular molds. Neither does nystatin. This was for GI Candida. Okay, you know, there's a lot of tests out there that are not validated tests that find all kinds of stuff that who knows what they found. Do the MyMycoLab test. And remember, anyone that does the test, once you get the results, you get a free Zoom call with me. So we can talk on Zoom. Do most of my patients have GI symptoms and or SIBO? A lot of them do. A lot of them do. Now, what happens when you get the test results along with the email? It says, and if you like, you can schedule a call with Dr. Campbell and click on here, and it tells you how to do that. So I'm not unavailable. I'm very available every week, every week. Now, next week, I'm not going to be available Thursday, Friday, Saturday, or Sunday because I have to go and give a lecture at the AMMG conference. And then in about 3 or 4 weeks, I give another one at A4M. So the sure, I mentor people all over the planet every time. That's the link, MyMycoLab.com. And I love to mentor people. I love it. And I give my cell phone freely. They can text me, call me, etc. I'm happy to help. As long as we help others, that's what we're meant to do. You know, we really help each other, and that helps people who are sick. And that's, to me, wonderful. All righty. So, folks, this was taped, and in a couple of days, you can get this whole webinar. And don't forget, for all my webinars, and you click on video at the top. Yes, it gets posted to YouTube. And I'll be happy to answer any questions. You can, you know, I'm here to teach. That was my third slide. Okay, folks. Well, it's 9:15, and here in Florida, sunny Florida. So for all my webinars, go to MyMycoLab.com and click on video. And I have webinars on autism, on women and children, the first 1,000 days, because, you know, mycotoxins are transplacental and come out in mother's milk. I did 2 on breast implants, because breast implants, inside the implant, whether it's silicone or saline, there's mold growth. And so remember that. And I gave them webinar on treatment, another one on children, and then the brain, part 1 and part 2. Okay, all righty, folks. Well, I hope you all enjoyed it, and have a great rest of the week.